Good afternoon. Bismillahirrahmanirrahim. Assalamu alaikum. Welcome you all to our today's session. Can you please stop the screen share, Hasim? Hasim, please stop your screen share.
Okay.
Yes, okay, thank you. So, I welcome you all to our today's session. Today we have a session on pancreatic cancer, and we are very happy that we could continue this session till last April, and we are keeping the effort of connecting people during this era of social distancing. And today our session is on the role of surgery, surgical management of pancreatic and periampullary carcinoma. And as you know, we always talk on how we treat our patient with evidence-based medicine. Our today's faculty is Dr. Hasim Rabbi, who is the Associate Professor, Department of Hepatobiliary Pancreatic Surgery, Bardem General Hospital, Shahbag, Dhaka. Just for Robert, Bardem is probably one of the largest hospital dealing with diabetes patient in the whole world, definitely in Asia. So he is representing that institute. And we are having our today's faculty is Dr. Robert Hutchins, who is a consultant hepatobiliary and pancreatic surgeon in Bathlumos and Royal London Hospital. And also we are happy to have our old face, known face, always smiling Dr. Mohammad Zakirullah, who is a consultant oncoplastic breast and general surgeon. In the same hospital he's working. So we welcome you both, the overseas faculty and our president and patron, Professor M.A. Hai, who will chair the session. Normally we start our session, few words from him. So I request our president, Professor M.A. Hai, sir, to start the session. Sir.
Thank you, Dr. Kamal. Bismillahirrahmanirrahim. My heartfelt thanks to all of you, particularly to Dr. Robert Hasim, who will join us today from England, and also Dr. Zakirullah from England, and our today's local faculty is Dr. Hasim Rabbi. Heartfelt thanks to all of you and all the participants for taking part in this today's session. Hopefully our session will be very interesting. We have got very renowned surgeons. So without any delay, I think we should listen to them and start immediately. Thank you all very much.
Thank you, sir. Hasim, now you can share the screen and start the presentation. Now over to you, Hasim.
Respected teachers, my fellow colleagues, good afternoon and assalamu alaikum. I am Dr. Hasim Rabbi, working as Associate Professor in the Hepatobiliary Surgery Department of Bardem General Hospital. And I'm going to present my topic on role of pancreatic surgery and periampullary carcinomas. We all know that pancreatic cancer and biliary tract cancer are both aggressive and highly fatal malignancies. Surgery is the only potentially curative therapy with frequent disease recurrence. In pancreatic cancer, adjuvant treatment with FOLFIRINOX has improved overall survival. And in biliary tract cancer, with capecitabine seems to improve overall survival and also the relapse-free survival. And neoadjuvant treatment is best in achieving R0 resection in borderline pancreatic cancers. Concomitant radiotherapy could also be considered following R1 surgery in both neoplasms. In metastatic pancreatic cancer, FOLFIRINOX or gemcitabine plus nab-paclitaxel has improved overall survival compared with gemcitabine alone. In metastatic biliary tract cancer, cisplatin plus gemcitabine constitute the standard treatment. A new targeted therapy with encouraging results has improved survival and quality of life. My topic is today mainly on role of surgery, but I'm not going in details regarding the techniques and others. And we all know that there are different kind of pancreatic tumors. There are benign, borderline malignant pancreatic tumors and malignant pancreatic tumors. There is a long list of tumors, but we mostly encounter the pancreatic ductal adenocarcinoma. adenocarcinomas. Pancreatic adenocarcinomas accounts for about 90% of the cases, and about only 1 to 2% of cases are neuroendocrine tumors. It's rare before the age of 40, but more than half of the cases of pancreatic carcinoma occurs over the age of 70 years. The risk factors of tobacco smoking is around 25%, obesity, diabetes mellitus, especially the newly onset diabetes, and genetic predisposition in 5 to 10% cases. We all know the symptoms for pancreatic cancer are mostly due to indigestion, upper abdominal pain, often jaundice, and pale, smelly stools, and fatigability. And most importantly, the unexplained weight loss. Approximately 70%, 75% of all pancreatic carcinomas occurs in the body and head and neck region. 75% of all pancreatic carcinomas occurs within the head and neck region, and 15 to 20% occurs in the body of the pancreas, and 5 to 10% occurs in the tail. And typically, pancreatic cancer metastases to the regional lymph nodes, then to liver, and less commonly to the lung. And also directly invades the surrounding visceral organs like duodenum, stomach, and colon. We are very much worried why the pancreatic malignancy is very much aggressive. There are some important issues like perineal invasion, early lymphatic metastasis, and liver-vascular invasions are very important. Hematogenous space occurs to liver, lungs, lymph nodes to peripancreatic and para-aortic lymph nodes, and sometimes extra-abdominal nodes. Adenocarcinomas of the head, 70% occurs in the pancreatic carcinomas and obstruct the bile duct, and small tumor at presentations. Direct invasion occurs to suprahepatic vessels and retroperitoneal organs and other adjacent organs. In body and tail malignancies, if they present late as they do not have any obstructive symptoms or others, so we usually commonly presents with big abdominal complaints and often without lacking pain. And usually they present when they are large. Perineal invasion, we all know the basics, but most importantly, the micro neurotropins, NGF family and NGDF family, they are cytokines, they are important. Another one important issue is the lymphatic pancreatic lymph nodes situated along the arteries and that supply the glands. The efferent vessels ultimately drain into the celiac nodes, superior mesenteric nodes. And sometimes we get the pancreatic head lesions, but there are numerous lymph nodes around the pancreas, especially the lymph nodes around the superior mesenteric artery, celiac trunk, and sometimes it gives impression of advanced disease. But we have sometimes become very much confused when the patients are previously decompressed by ERCP with stent and they present with recurrent cholangitis. We become confused whether these lymph nodes are due to infection or inflammation or due to lymphatic infiltration. We all know the staging of the, we are very much worried about the staging of the pancreatic malignancies. According to the JCC classification, there are 4 stages. At stage 1, that 7% present actually at the age of at early, 7% only present stage 1, and they have only 20% 5 years survival rate. And stage 2 disease are 26% present at stage 2 and 3, and 26% present at stage 2 and 3, and 8% only have the 5 years survival rate. And 53% patient present at stage 4, and only 2% have the 5 years survival rate. This is the JCC 7 edition classification, but if you compare the 7th edition and 8th edition, we have seen that the 8th edition, the classification has become more elaborated, and the important issues, the main differences are the stage 2, stage 1 disease are mostly less than 2 centimeter, and stage 2 is the tumor 2 is the in between 2 to 4 centimeter, and T3 is the more than 4 centimeter graded dimensions. The most important thing is that stage 4 disease tumor involves the celiac axis, SMA, and common hepatic artery. And another important thing is that when we see that regarding the lymph node, what I have mentioned earlier, when it is less than 4 regional lymph nodes, we consider it as N1, and when it is more than 4 and the regional lymph nodes, we consider it N2. So we become in dilemma whether the patient is an N1 and N2 when making a decision for resection. If we consider the outcome of the pancreatic malignancy, only 5% of pancreatic ductal adenocarcinoma patients survive 10 years, and this incidence is rising, and it's usually diagnosed at the advanced stage due to particular aggressive biology and non-specific symptoms. Only 5 to 20% of the patients are the candidates for surgery at presentation, and 2/3 of them usually recur. Despite adequate oncologic resections, 76 to 82% of the patients have positive resection margin. It means around 76 to 82% R1. And recurrence rate at 2 years is around 70 to 80% in either local or distant metastasis. So the concerns what are the concerns in the pancreatic cancer management are? The main concern is the early detection. Most of the patient presents to us late, and before planning for a definitive management, they usually go to different centers for proper treatment, but different kind of interventions were done before, especially the endoscopic maneuver, which gives a false impression of resectability. So surgical strategy for planning the pancreatic cancer management is very important, and it's challenging. So with the help of our oncology colleagues, we are now very much confident in making a decision whether we should go for a neoadjuvant management and planning for the adjuvant management. So we are trying to make an oncology board before making any kind of decision. So besides, targeted therapies are also important. What are the key questions in the management? Timing of the events as the disease develops, how and when the disease spreads and progress, and the recent onset of diabetes. So basically, there are when making a surgical strategy for specific or definite management, whether we should go for whether it's a resectable lesion or borderline resectable lesion, it means a locally advanced disease, or unresectable or metastatic disease. So the options are surgery with chemotherapy, or chemotherapy followed by surgery, or chemotherapy. There are different guidelines for the practice. So this is for the clinical presentation. The NCCN mentioned that clinical suspicion of pancreatic cancer or evidence of dilated pancreatic duct or bile duct, especially when we when the patient we see the CT scan or MRCP, we find the double duct sign. We become very much curious about the type of the lesion. We go for the CT scan, and we try to identify the mass lesion in the pancreas. If there is a mass lesion and without any metastasis, we usually go for surgical resection. And when there is a metastatic lesion, definitely after staging, when there is a metastatic lesion, we usually confirm the metastasis by doing a biopsy with an FNAC and confirm the metastatic disease and go for the chemotherapy or for the management. If there is no detectable mass lesion, but with signs of dilated main pancreatic duct and biliarity, we go for further evaluation whether there is a neoplastic lesion hiding behind this. So we go for an endoscopic ultrasound, but in our country it is not that much popular or not practiced, because it's not available in every center. And we go for liver test, and the recommended liver function test, X-ray, MRI, and MRCP and ARCP as clinical indication. Usually, what is the recommendation in our textbook is that when the bilirubin is less than 10 and there is no detectable mass lesion, we go for ERCP to go make any kind of possible cytological diagnosis by blood cytology, so we can make a decision for surgical management. When the patient presents with jaundice, with no symptoms of cholangitis or fever, we usually evaluate the patient for surgery. And we actually follow the NCCN guideline. And when there is cholangitis, we usually consider whether this patient is having a stent, whether it's a self-expanding metallic stent or a plastic stent. When there is a self-expanding metallistan, the dissection and surgery becomes difficult, and it gives the false impression of resectability due to localized pancreatic inflammation, like mass lesions or inflammatory lesions. So we work up accordingly whether the lesion is a resectable, borderline resectable, or locally advanced disease, or a irresectable lesion. When it's a resectable lesion, we consider sometimes, not always, we sometimes consider staging laparoscopy, as there is no signs of resectability. So surgery, we go for directly laparotomy, and we plan for partial pancreatic, especially the Whipple's procedure. We personally prefer Whipple's procedure with Brown's anastomosis, and in few of our cases, we did Pancreas preserving pancreatectomy. If we consider this Japan Pancreas Society guideline, published in concept 2019, they are also highlighting that whether there is a resectable tumor or resectable tumor, surgery should be given preferred in case of resectable lesion. In case of borderline resectability or unresectability, we should go for they have preferred neoadjuvant chemotherapy, followed by reassessment for surgical resection. And if it's possible, then we should go for adjuvant. After surgery, we should go for adjuvant chemotherapy. And if it is not surgical resectable, we further consider the chemotherapy and reassess. And or if it's not, then we should go for continuing the treatment. For locally advanced disease, neoadjuvant chemotherapy is preferred, and the first line treatment is gemcitabine monotherapy, and besides FOLFIRINOX or gemcitabine with nab-paclitaxel and combination therapy. And the management strategy, so far we have seen that the pancreatic surgery is the main strategy that gives the hope of cure. Besides, even if it's not curative resection, it improves the quality of life. But the early palliation is always recommended for the aim of cure. The history of pancreatic surgery is a bit gloomy, because it was first attended by an Italian surgeon, Alessandro Codiviglia, in 1898, and the patient only survived for 18 days. In 1912, German surgeon Walter Koch was first to remove the large part of duodenum and pancreas and blood. And in 1935, Sir Alan Wolford Whipple's published his first article on Whipple's procedure of 3 patients. Only 1 patient had duodenum entirely removed, and it survived for 2 years. And during this period, they have shown that only about 25% of people never left hospital alive as late as 1970s. And during 1970s, a group of American surgeons wrote that the procedure was so dangerous that it should be abandoned. In 2006, a report published 1,000 consecutive pancreatic duodenectomy was published by a single surgeon from Johns Hopkins Hospital in between 1969 to 2003. And later, the same surgeon has published another article of 2,000 consecutive surgeries in the recent articles. And it has shown that it is not that dangerous. The planned surgery and proper multidisciplinary approach and planned surgery can give a good result. So decision is more important than incision, what we have learned in our training period. So what are the criteria of the irresectability? Head tumors with distant metastasis and greater than 180-degree SMA encasement with celiac abutment or inferior with inferior and also inferior vena cava, and unrecognizable SMA and unreconstitutable SMA, SMV, and portal occlusion is signs of irresectability. Besides, aortic invasion and encasement is signs of irresectability. For body tumors, distant metastasis, SMA encasement greater than 180 degree, and unreconstitutable SMA, SMV is also occlusion, is also with aortic invasion is also irresectable. This apart from that, the same is applicable for the tail tumor. In the nodal status, metastasis to lymph nodes beyond the field of resection should be considered irresectable. So if we see the consistent guidelines, there are basically three important issues: whether the lesion is resectable, borderline resectable, or unresectable. So, and there are details, technical issues. I'm not going in details of arterial venous invasions, but the importance is that there is a question whether we should go for neoadjuvant therapy for all patients. The potential benefits for neoadjuvant therapy are avoid surgery in patients with widely micrometastatic disease, potential downsizing the tumor to avoid vein resections, and examination of the tumor biology. The demerits of resectable tumors become unresectable during this period, and complications of chemo occurs due to delayed surgery, and there is increased chance of complications. So, in case of borderline resectable non-metastatic pancreatic cancer, neoadjuvant systemic therapy should be given in patients with borderline resectable pancreatic adenocarcinomas. The recommended duration is 2 months. FOLFIRINOX is the preferred above gemcitabine with nab-paclitaxel, and neoadjuvant chemotherapy, including stereotactic body radiotherapy following neoadjuvant chemotherapy, might improve R0 resectability rates. Adjuvant systemic chemotherapy should be given to all patients after surgical resection of borderline resectable pancreatic adenocarcinomas. Recommended duration of adjuvant chemotherapy is 4 months, and it is addition to 2 months duration of neoadjuvant chemotherapy. So overall duration is to cover the 6 months in total. In case of locally advanced, unresectable, non-metastatic pancreatic cancer, it's to the neoadjuvant systemic chemotherapy should be considered. The FOLFIRINOX is preferred, same as the above the gemcitabine with nab-paclitaxel. And in patients with distance metastasis, chemotherapy contributing to a delay in prevention of local progression. Palliation during this period, pain and obstructive symptoms should be considered. Surgery, local ablation, radiotherapy, chemotherapy should be preferred. So the important is surgery is all over. High quality imaging after 2 months, every 2 months is recommended to reassess whether there is chance of resectability. If it becomes resectable, surgery should be considered, followed by adjuvant systemic chemotherapy, and followed by the adjuvant chemotherapy. Surgical resection is the standard and potentially curative treatment in locally resectable pancreatic cancers. The main goal of surgery is to achieve the tumor-free margin, R0 resection. Standard neoadjuvant therapy is currently not recommended in this group, and we all know that for head and unsinate process lesions, pancreatectomy is the treatment of choice. For body and tail tumors, distal pancreatectomy with en bloc stenectomy is recommended. And for BRCA mutant cancer, total pancreatectomy should be done. For resectable pancreatic cancers with synchronous liver metastasis, resection with both the lesion in case of solitary metastasis is the preferred treatment of choice. Resection of the liver metastasis with locally resectable pancreatic cancer has rarely been performed. Recently, promising results regarding the morbidity and mortality as well as long-term survival has been reported. Resectable pancreatic cancers with oligometastasis. The oligometastasis is defined as when there is less than 5 metastases in single organ. Although surgery is not recommended in metastatic disease in pancreatic cancer, but there might be some role in highly selective patients. Management of patients in this group with resectable pancreatic cancer with surgery should be considered and should be discussed with the patient by a tumor board. Metastatic pancreatic cancer should be treated with systemic pancreatic cancer, and same as the FOLFIRINOX and the gemcitabine with nab-paclitaxel is recommended. Radiotherapy can be applied for palliative purposes, but when it becomes resectable, the resection becomes very difficult. In case of metastatic pancreatic cancer, the systemic chemotherapy should be the choice, and the first line is the FOLFIRINOX and the gemcitabine with nab-paclitaxel. But here is the most important thing: the management of endoscopic endoscopic interventions is very important because the surgical sometimes when the surgical endoscopic palliation is difficult, surgical palliation should be considered when like severe symptoms of obstruction like gastric obstruction, duodenal obstruction, and definitely biliary obstruction. But definitely that when the cannulation through endoscopy is difficult, the surgery should be considered. But palliative care should be focused on comfort, nutrition, and quality of life. In case of local recurrence after resection of the pancreatic cancer, surgical resection of the regional recurrence resected pancreas, re-resection is not recommended. In case of local recurrence without metastasis, surgery with or without neoadjuvant therapy can be considered. Recurrent pancreatic cancer should be treated with systemic chemotherapy. Patient's preference should be always given to evaluate and regard the nutrition and pain assessment. There should be the important main issues apart from the obstructive jaundice is severe pain. Usually, when we go for surgical palliation, we also consider celiac access neurolysis during this period, but sometimes it's not that rewarding. Patients with pancreatic cancer should be offered specific psychological support from professionals belonging to the multidisciplinary team. The main challenges are pain, anxiety, psychological issues. There are some metabolic factors and GI problems. The management during this period all focuses on malnutrition. Patients' psychological factors like depression, loss of appetite, metabolic factors like diabetes mellitus due to cancer resection or Warburg's effect, and pro-inflammatory cytokine release like tumor from the tumor cells like interleukin 1, interleukin 6 tumor necrotic factors. Besides, gastrointestinal factors are also important because pancreatic endocrine insufficiency also a big challenge in major pancreatic dissections. And besides, anastomotic diversions are also contribute to this, and small bacterial infections. Another challenging entity is the cystic neoplasm of the pancreas. Sometimes it really causes a diagnostic dilemma and results into therapeutic uncertainty, whether we are very much concerned whether these lesions are really true cyst or secondary cyst or pseudocyst. Or very important issues are whether this is a neoplastic cyst or non-neoplastic cyst. So when there are neoplastic cysts, we consider that these are mostly IPMN, mucinous cystic neoplasms as well as cystic neoplasms. Pancreatic cystic neoplasms presents 2 to 45% in the population, and PCN comprises clinically challenging entity as their biological behavior ranges from benign to malignancy. Different recommendations are there, like European guidelines, International Association of Pancreatology, and American Gastroenterology. There are different guidelines, but the most important thing is that growth rate of serial follow-ups are very important, apart from clinical evaluation and cytology, that whether this is a solid lesion or a cystic lesion or a solid cystic neoplasm, and whether these solid cystic neoplasms are associated with pancreatic ductal dilatations, and there are any focal nodularity or lymph node metastasis or associated lymphatic enlargement, lymph node enlargement. So the surgery is the mainstay of treatment, and we consider it on all the guidelines. Surgery is given priority, but it should be planned according to the evaluation findings. Regarding the cystic fluid tumor marker, apart from CT-guided or image-guided final aspiration cytology, we also prefer to do cyst fluid tumor markers, and mainly we do the CA19-9 level, amylase level, and CEA. In very selective cases, CA 72-4 is recommended, but we are not practicing that one. If the CA19-9 and amylase level is raised in the cystic fluid, it means when it's high, this is definitely a pancreatic pseudocyst. But when CE level is high, that indicates that whether it is a neoplastic cyst, and most likely it is a IPNN, introductory papillary mucinous neoplasm, or a mucinous cystic neoplasm. But all the tumor markers is low in the cases of serous cyst adenoma. But in case of serous cyst adenocarcinoma, amylase level may be high. If we consider the introductory papillary mucinous neoplasm, it is a cystic neoplasm of the pancreas with malignant potential that grow within the pancreatic duct and produce mucin. The risk factors are diabetes, chronic pancreatitis, family history of pancreatic ductal adenocarcinoma, and smoking. MRI and with MRCP is the first line of investigation, and it may be supplemented with CT scan where there is diagnostic dilemma. But endoscopic ultrasound with FNA has a very vital role. Large size with dilatation of main pancreatic duct with the presence of a solid component is a suspicion of IPNN. Cystic with cytology for atypical malignancy and raised CEA gives the impression of IPNN. The conservative approach is recommended for the asymptomatic NCCN and IPNN measuring less than 4 centimeters without any enhancing nodule. Relative indications for surgery is IPMN include that MPD diameter between 5 to 9.9 millimeter or 9 to 9 millimeter, or cyst diameter more than 4 centimeter. Absolute indication for surgery in IPN due to high risk malignant transformation, including jaundice, enhancing mural nodule more than 5 millimeter, and MPD diameter more than 10 centimeter. 10 millimeters, with raised serum C99 level. Lifelong follow-up of IPMN is recommended in patients with patients who are fit for surgery. If we consider the radiological aspect of the IPMN, there is absolute indication for surgery is in patients with significant comorbidities, or patients without significant comorbidities with one or more relative indication for surgery, and patients with significant comorbidities and 2 or more relative indications for surgery. If we consider the mucinous cystic neoplasm, when it is more than 4 centimeter and also symptomatic with high risk and high risk factors like mural nodule, irrespective of their size, should undergo surgical resection. Considerably faster growth with NCCN occurs during pregnancy, potential leading to tumor rupture has been reported. Therefore, should be observed closely during pregnancy. And it is safe to follow up presumed NCCN when it is less than 4 centimeter in the absence of risk factors and suspicion of mural nodule. Serous cystic neoplasm, these are usually benign. There are no reports of death attributable to dissemination or malignant behavior of the serous cystic neoplasm. Especially specific mortality due to SCN is nearly 0. Size of 60% of serous cystic neoplasm remain stable. Increased size seen only in 40% of cases, but the growth rate is very slow. But new onset of symptoms are very rare. Surgery is recommended only in patients with symptoms related to compression to adjacent organs like bile duct, stomach, duodenum, and portal vein. We have very good experience of dealing with patients with solid-pseudopapillary neoplasm. This mostly affects the young females in our clinical experience. And these are, in these cases, these are actually potentially with malignant potentials. Radical resection should be performed in all solid-pseudopapillary neoplasms. Even in the absence of large series, the surgical resection with SPN is internationally recommended and associated with positive long-term outcome. The question is, can locally advanced SPN be resected? Should synchronous or metastasis be resected? In cases of locally advanced and metastatic recurrent SPNs, an aggressive surgical approach and complete resection is indicated. In case of pancreatic neuroendocrine neoplasm, definite diagnosis of pancreatic neuroendocrine neoplasm can be established only by histological examinations. So preoperative diagnosis is difficult and often suspected on cross-sectional imaging and can be confirmed by ultrasonography, endoscopic ultrasonogram, and with FNA. Cystic pancreatic endocrine neoplasm often have peripheral hypervascular rim visible on arterial face of contrast CT, multi-director contrast CT, and SCN may have a similar appearance in the CT scan. Data on functional imaging with ocular scan, and we don't have an experience actually of cardiac scan on ocular scan PET CT. We have seen few reports of juvenile neuroendocrine tumor as well as periampullary neoplasm. We actually consider this periampullary group. What we have done in case that we have diagnosed these cases of periampullary neoplasm and went for resection. And resection is recommended if less than 1 centimeter and no suspicion of lymph node metastasis. Resection is recommended when there is more than 1 centimeter lesion and without suspicion of any lymph node metastasis. Juvenile neuroendocrine tumors with less than 1 centimeter lesion, these are endoscopically resectable. One of our eminent Professor Tawhidul Tawhid is very good at doing this kind of endoscopic resection. And the duodenal neuroendocrine tumor between 1 to 2 centimeter endoscopic resection, if possible, can be considered, but surgery, radical surgery with lymphadenectomy should be considered. And neuroendocrine tumors, duodenal neuroendocrine tumors more than 2 centimeter, radical surgery with lymphadenectomy is recommended. What we have finally considered that whether the resectable lesion or resectable lesion, when the resectable lesion is in the head of the pancreas, we consider the partial pancreatic duodenectomy following the Whipple's principles. Whipple's, we all know it is a Whipple's procedure. When it is in the body and tail of the pancreas, we go for distal pancreatectomy with distal pancreatic. In benign cases, we prefer spleen preserving distal pancreatectomy. In neck lesions, we consider that distal pancreatectomy with splenectomy, and sometimes it's very important whether we have not sometimes it's actually very important whether we have cleared the supramesenteric artery or not. I'm not going into the details of the surgical techniques, but one of the most important issues is whether we are removing the mesopancreas or not. It means the lymphatics and the neuronal, we are actually what I have highlighted in my earlier part of the presentation, that lymphovascular invasion and perineural invasion are very much important and contributes to the early recurrence of the pancreatic cancer. So mesopancreatectomy, the removal of the mesopancreas is very important here, and what we have seen that SMA clearance is very important here. So the proper mobilization of the portal vein and the superior mesenteric vein, along with and the dissection of the superior mesenteric artery and skeletonizing it, and the flush ligation of the inferior pancreatoduodenal artery is very important with the clearance of the superior mesenteric artery. And if we don't remove the vein of Belcher and first jejunal vein, it is very impossible to skeletonize the superior mesenteric artery. There are good number of articles nowadays that there is people are different in different centers. They are doing venous excisions, reconstructions, as well as graft reconstruction with grafts. But we are not good at reconstruction with graft, but we have done small resections of veins with repair with venous patches in only 1 or 2 of our cases. But the important thing is that the proper portal drainage should be ensured after reconstruction, because this group of patients needs long-term ICU support, and mostly it's difficult to, sometimes it's very much difficult and challenging part is to correct the metabolic acidosis or persistent metabolic acidosis after venous reconstruction or repair. There is a good debate whether we should go for a Whipple's partial pancreatiduodenectomy or a pylorus preserving pancreatiduodenectomy. Both the procedures are recommended in the, there are different articles, but what we prefer here that Whipple's partial pancreatiduodenectomy with the Brown's anastomosis, it means the side-to-side anastomosis after the gastrogenostomy gives a very good outcome and prevents the bile reflux gastritis. And pylorus preserving pancreatiduodenectomy is preferred in the periampullary lesions. There are different methods of reconstructions. This is another method because there's a P-loop reconstruction. Besides, nowadays there are a good number of articles and showing good results with pancreatogastrostomy. This is one of my diagrams prepared for my students, but in case of benign lesions, we do the middle pancreatectomy, or also known as central pancreatectomy, in which we remove the central of the pancreas tumor, and we reconstruct the we are not actually reconstruct. We usually repair the proximal duct and stump, close the stump, and we drain the remnant pancreas into the jejunal loop. Another important lesion procedure is the RAMS procedure. In earlier part of our career, we have done only distal pancreatectomy with splenectomy. But for last couple of years, we have seen that the removal of the mesopancreas also very much important in this group of patients with neck lesions, because here also the clear SMA, supramesenteric artery clearance, also important. The RAMS procedure is the radical antegrade modular pancreatisplenectomy. Is due to in which the removal of the mesopancreas surrounding the supramesenteric artery is very important. Otherwise, there is every chance of recurrence. There are two types of procedure. One is an anterior approach and is a posterior approach. And posterior approach, in my view, is very pretty much difficult because sometimes it may have to remove the adrenal glands. But I don't have any experience removing doing the posterior approach. I have experience of doing cases of anterior approach. There is another challenging. This is another challenging issue: whether the pancreatic resection is possible in case of locally advanced disease encasing the celiac trunk and the supramesenteric artery. There is a new technique, especially highlighted in our last World Congress of IHPBA, and we have seen there are articles also published in HPB journal that Heidelberg's technique is very rewarding in case of locally advanced disease encasing the supramesenteric artery and the celiac trunk. The approach is neoadjuvant therapy with FOLFIRINOX and gemcitabine and abraxane, stable disease. And if the disease is progressing, palliative therapy should be considered. But if the surgical exploration reveals with frozen section the critical site, no vital tumors, and the triangle operation without arterial resection is recommended. And the triangle operation is the total pancreatectomy with splenectomy with resection of the portal vein and inward portion of the supramesenteric vein and portal vein. And this great triangle is the triangle, also a hereditary triangle. But I don't have any experience regarding. I'm not expert like doing this kind of procedures till today. But hopefully, I'll be able to do it in the near future with the help of my oncology colleagues. There is another. There is always the role of extreme surgery in all the malignant diseases. This is another procedures. This is a modified Appleby technique in which classical total pancreatectomy with en bloc resection of the spleen, en bloc resection of the celiac axis, portion of the SMV and portal vein, subtotal gastrectomy, HJ, hepatic jejunostomy, gastrostomy, Brown's and clerestomy, and along with subcutaneous gastroctomy and removal of the aorto common hepatic artery, interposition of graft with the endos and the portal veins, SMV anastomosis is done. But this is a very difficult surgery. I've never seen it. So in conclusion, pancreatic cancer is a disease with dismal prognosis, even with a curative surgery, even with a surgery with curative intent. Resection represents the only hope for long-term survival. Negative resection margin with R0 resection represents a strong independent prognostic factor. The area most involved by the positive resection margin is the mesopancreas, which results into 80% of the local recurrence within 1 year. So we should be very much cautious during surgery whether we are skeletonizing the superior mesenteric artery, especially during Whipple's procedure. Flush ligation of the origin of the infrapancreatic artery is very vital, and total mesopancreas excision is presumed to decrease the rate of R1 resection and improve the survival. Neoadjuvant therapy is an important strategy for locally advanced pancreatic ductal adenocarcinomas, as resection rate increases up to 60% with modern chemotherapy regimes, even with arterial tumor encasement. Thank you.
Thank you, Dr. Hasim, for the elaborate presentation. Can you please stop your screen share? I would like to request Dr. Robert Hutchins to make some comments on the presentation, then we start our discussion.
Yeah, thank you very much. That was an excellent run through the management of pancreatic cancer in a short period of time. A huge amount of information there, and the vast majority of it very much evidence-based and very much what the world does. You know, I was looking at most of those slides and thinking, yep, that's exactly what we do. That's what we do. Perhaps a couple of just additional bits of information rather than any comments on the talk, which may just help people in terms of their decision making. We looked at, we know that we're not offering surgery generally for metastatic pancreatic cancer. And we know that we're offering surgery for resectable pancreatic cancers. And then there's that group in between of the borderline and the locally advanced tumors, where now we tend to offer neoadjuvant therapy to those people to try and downstage them. And there are a huge number of different neoadjuvant regimes. But probably, and we heard that FOLFIRINOX constantly gets mentioned over and over again. And you might argue, well, what about using Abraxane, gemcitabine? What about the addition of radiotherapy or not? What should we be doing? And the reason that FOLFIRINOX is front of queue, as it were, is FOLFIRINOX has the largest numbers in terms of evidence base in order to demonstrate successful downstaging. And generally speaking, FOLFIRINOX has better downstaging results than things like gemcitabine Abraxane. And even if you add radiotherapy onto FOLFIRINOX, actually FOLFIRINOX alone seems to have better downstaging without radiotherapy than the addition of radiotherapy. And you're looking at downstaging rates variously reported, anything from sort of 30 to 60% of patients with borderline tumors get to have surgery. And that brings you on to the question of, should we be doing neoadjuvant therapy for everybody? Because we certainly now look at rectal cancers, we look at gastric cancers, we look at various other tumors around, and neoadjuvant therapy is not a new idea. It's been around for a while and it seems to be very effective. The problem with resectable disease is that uptake to clinical studies is very low, because you can imagine that if you're told your tumor can be removed, would you like to have it removed, or would you like to have neoadjuvant therapy? The vast majority of people are a bit hesitant to volunteer themselves for the chemotherapy arm of any trial. So it's been difficult to recruit to resectable tumor trials. There is some evidence now that actually you can get very good results with neoadjuvant therapy in resectable disease as well. There's always an argument, what about the people that progress? And my argument there is always the people who progress are very likely to be the extremely poor biology patients who, even if you offered them upfront surgery, are going to be those disappointments that have metastatic disease in their first or second surveillance scan after an operation. And the argument for neoadjuvant therapy as well is, if you look at surgery alone, and we saw some very good figures about surgery alone for pancreatic cancer, we're not fooling ourselves. We're not curing people. We're generally buying people some time. And we know that we can add to that time if we give them adjuvant therapy. And all the evidence from the adjuvant therapy trials is that, unfortunately, this type of surgery is such a physiological insult to the body that less than half of people will get to a full course of adjuvant therapy after a Whipple operation. And the argument then is, well, if you can give them neoadjuvant therapy, there's some good evidence that they're more robust nutritionally and physiologically when they come to their operation. There's some evidence that the morbidity of their operation is reduced, because there are certainly changes in the pancreas that occur with neoadjuvant therapy. And the surgery is the last thing they need. So it doesn't matter if they take 2 weeks to recover or 2 months to recover, because they're not waiting for any other aspect of their treatment. So they're the sort of arguments behind neoadjuvant therapy and why it might be a good idea. The other thing we didn't get on too much was the fact that when you're selecting patients to be re-explored after neoadjuvant therapy, you are not basing it on a CT appearance. The CTs very often remain the same. And we know that a lot of viable tumor is converted into fibrous tissue, and therefore the scan looks the same, but you still have to offer them exploration as long as they haven't progressed on their follow-up CT scan. And you can go down that road even greater in even greater detail and go down the Mayo type of approach, which is supremely aggressive, as the Mayo are for pretty much everything. They will wait until your CA19-9 falls and your PET is negative before they re-explore you. And that might mean that your neoadjuvant regime continues for 6 months or 8 or 9 months or 12 months or even 18 months before you get your operation. And as always with those Mayo Clinic patients, they are very highly selected, and the results, you have to analyze their patient selection and their demographics very carefully before you just recommend that for everyone. But it does take us into another issue of staging, which is PET scan, because I mentioned that the Mayo Clinic used PET scans to follow up their neoadjuvant regime. Now in the UK, we do use PET imaging as part of our routine workup of pancreatic cancer. And that comes out of the PET-PANC study, which demonstrated that, you know, in 20% of people, you would change management correctly and not offer them surgical intervention. So there were some of my comments about that. The other thing about cystic tumors, which people always ask, again, you know, absolutely everything in that talk is what we do in the United Kingdom. The question then is, if you put someone on a follow-up regime because they have a small asymptomatic benign looking mucinous tumor, how long do you follow them up for? And the honest answer is, we don't know. There's a big argument at the moment whether, and the European feeling is that after 5 years, if nothing has happened, surely you can stop follow-up. And the American feeling is, well, no, if we've already declared that this is something that is pre-malignant, surely it doesn't stop being pre-malignant just because you've got to 5 years, and therefore your follow-up is lifelong. And there are huge economic consequences of following up cystic lesions, which are incredibly common. And I'm sure Hasim will back me up in this. Your MDTs are just flooded with incidental cystic tumors now, loads of them, you know, and it takes up a lot of time and a lot of resources from healthcare to have to follow all those people up for life. But the honest answer is, we just don't know whether it is safe to stop surveying them after 5 years. But very, very enjoyable talk. And there are some of my comments, which hopefully will answer some questions.
Thank you, Robert. Hasim, can you please stop your screen share? So let me raise few issues, maybe very silly for the surgeons. Sometimes we find a patient, the CA19-9 is not very high. The radiologist is telling that it is doubtful. We are not very sure. So sometimes we are scared to put a needle like FNAC because it is pancreas, putting a needle can create a havoc. So any comment on that? I mean, when we are suspicious, can we put a needle to find out whether it's malignancy or not?
Yeah, sorry, I think it's perfectly safe to do endoscopic ultrasound and look at the pancreas in more detail with endoscopic ultrasound and see if there is a mass, and if there is, sample that. Absolutely fine.
Regarded FNAC from outside?
I think in terms of FNA from outside, I think blind FNAs where you don't see a mass, it should be avoided, because there is not a hope in hell of you picking up a malignancy. We know how difficult it is to diagnose a malignancy, even with microcores, when you can see a mass and you can see your needle go into a mass. Blind, you're never going to pick up the diagnosis. You then come to what if you have a mass? Is it then safe to do percutaneous sampling of that mass? We tend not to do it. We tend to go for the endoscopic ultrasound approach. Obviously, there are some patients where they're not fit for surgical resection, but they are fit enough for chemotherapy. And most chemotherapy will not be delivered without a tissue diagnosis. And therefore, obviously, we will consider percutaneous biopsies on those patients. But I think most of our patients where endoscopic ultrasound has failed to get a diagnosis, but there is a clearly visible malignant looking mass, we would try and persuade the patient to go for upfront surgical resection rather than waste time getting multiple percutaneous biopsies, with that small risk of seeding as well?
Well, Rob, say I'm not a surgeon. 3 surgeons has done a Whipple's. So, we see the performance of the surgeon. We are not surgeon, but we are supposed to judge the performance of the surgeon. So can you give us some tips how to say it is a wonderful Whipple's done? I mean, what are the tips that as a non-surgeon, I will look at the surgery note or the pathology note that will tell us, well, doctor, a adequate surgery is done.
So yeah, I think one of the important things about surgery is knowing when not to operate. One of the important things about if you look at the cohort of patients who've had a Whipple, do they come through their Whipple operation relatively unscathed in terms of complications? Now, we know that around the world, the morbidity of a Whipple operation is quite frightening still. If you look at all complications, not just the few selected ones related to the procedure itself, the morbidity is probably around 50%, and that includes episodes of AF, MIs, chest infections, not just pancreatic leaks. However, your pancreatic leak rate is actually a pretty good indicator of the standard of your surgeon. If you have a surgeon who has a 90% pancreatic leak rate, that is an unacceptably high level of pancreatic leak. So it is one of those factors you can look into. How many are you doing and what's your pancreatic leak rate? And that will tell you a little bit about your surgeon. Obviously, the other thing about your surgical ability during looking at your pathology report is I don't think any surgeon should be criticized for an R1 pathology report, because we know the vast majority of our cases will end up as an R1. I think there should be some doubt if all of your reports are R2, because it would suggest that you're not selecting your patients properly and you're not offering them the right treatment option in terms of neoadjuvant therapy first. And then it's a case of, how well do you look after the physiological insult to your patient? So how concerned are you as a surgeon with making sure that physiologically they go back to normal in terms of nutrition, the requirement for exocrine replacement and things like that? And I think if you look at those 3 things and you talk to your patients, you'll get a very good idea of who's doing a good job in a hospital and who's not.
Thanks, Robert.
Rob, can I ask, sorry, Kamal?
Yes.
Can I ask Rob one question? I mean, of course, it's a fantastic presentation, Hasim. Thank you very much for your presentation. And Rob added on that as well. As a surgeon, general surgeon, of course, I was involved with pancreatic surgery once or twice, but I'm not a pancreatic surgeon. I've got very limited knowledge about that. However, from the knowledge what I gathered before, that with all this kind of research, with all this kind of chemotherapies and neoadjuvant chemotherapies, in the past, the cure rate was 1% from the pancreatic cancer. Has it actually increased now? I'm talking about cure rate, not the resection rate. That is number 1. Number 2 is, when you do the pancreatic, especially the Whipple's procedure, is there any particular number of lymph nodes you have to take out from the celiac axis and other areas as well that you have to consider when you do resection, rather than just, I've seen some surgeons taking only 1 lymph node out, which is possibly not a very good resection margin. So these 2 questions to Rob, how do you normally decide?
Yes, so do we cure patients? That's a great question, because there are some very, very, very eminent HPB surgeons in the past who have followed their patients up beyond 5 years, beyond 10 years, and have come up with a very dismal view of pancreatic surgery, which is inevitably everyone will recur if you follow them up for long enough. If you look at 5-year survival rates, and certainly if you look at 5-year survival rates, R0 resections, followed by a full course of adjuvant therapy, yes, we without a doubt have changed the 5-year outlook, at least, for pancreatic cancer patients. And you can get 5-year survival of 10%, 15% in that group of patients. The problem, as ever, is looking at the evidence, and you look at the evidence and you say, well, what percentage of people had an operation where they had an R0 resection and then they completed an adjuvant course of chemotherapy afterwards, and it's very, very low, and that reflects, you know, as I said before, the physiological insult of a Whipple operation, the amount of time it takes to get over. So I would argue, yes, we have improved the 5-year survival. We will probably improve it further, because it is very likely that FOLFIRINOX is going to become the gold standard in all sorts of ways, whether it be adjuvant or neoadjuvant, and the groups of patients that we give FOLFIRINOX to. The sad fact is that the majority of patients still will present late, will not have an operation, and we don't do them very well, a good service. Looking at your second question was the lymph node count, and again, the lymph node count, we would very much want to be able to stage the patients properly, and as you saw, there are now N1 and N2 stages for pancreatic cancer, and I think you should be aiming for a minimum of 4 lymph nodes, but preferably, when we look at our specimens, 10 lymph nodes is probably the average that we get.
Thank you, Rob. Yeah.
And we send different groups of, so you'll have peripancreatic nodes, which are obviously within the main specimen, but actually outside the main specimen, we'll send those nodes off separately and we'll label them separately.
Absolutely. My last question is to Hasim. You did mention about this palliative support team. Do you have, or do we have anything in Bangladesh, this proper palliative team to look after your pancreatic patients or pancreatic cancer patients?
Very much unfortunate to say that we don't have a good palliative care support system here in Bangladesh. But nowadays there are a few centers coming up with the hope of that they will be able to continue, or contribute in a better manner, not like Western world, but probably they'll be able to contribute well in this arena. So there are a few centers, and they are also providing home care service in actually urban areas of Dhaka, and few in probably 1 or 2 in Chittagong. Mainly it's available in Dhaka actually.
That's brilliant. Absolutely, something is really good. And before I finish, last thing is, sorry, when we are talking about, this is completely 2 different countries, so I'm not comparing United Kingdom with Bangladesh, but here we try to give all the information to our patients and realistic impressions that if patient is diagnosed, sometimes we said, unfortunately, this is going to kill you. In that, we can't predict the time, but at least, but we probably don't say that thing to our Bangladeshi people, and mostly relatives ask you not to give all this information. So how do you tackle that situation when you are actually clearly lying to the patient, that giving false hopes or false impression? How do you manage?
This is a very challenging topic because most of our patients are not that well educated. They consider that whether there is a tumor, when there is a tumor, that's probably they think that this is probably not malignancy or there is not cancer. They think that probably cancer and tumor are two different things. Most of these patients are accompanied by their attendants. So they usually request us not to give the full information to the patient. And they usually ask us to give us the limited informations like that probably he or she may need a small surgery that is probably obstructing his biliary system, causing the jaundice, and he is unable to take food, or he or she is having bleeding. So probably this surgery may cure him or her, and he or she may need, after the surgery, may need chemotherapy for that. But when they hear that there is a word chemotherapy, they become frightened about the thing, what's going on. That's why most of the time we usually avoid giving information regarding the chemotherapy. But probably this should not be done, because after the surgery, we have, in our experience, we've seen that good number of patients become lost from our follow-up, and 6 months or even 1 year later, we have seen that they have presented to us with the recurrence or a lymph node around it, around the resection margins, whatever. But we have seen few of our cases. So that's why we are nowadays practicing that we are actually not giving full information to the patient, but trying to fully educate the patient's attendant, especially his or her son or daughter, regarding the treatment plan.
Thank you, Hasim. Thank you.
I think I would add to that we're in the opposite situation, where unfortunately, unless you give the patients and their families every scrap of information about their disease, they will sue us. You know, and it's a terrible thing to be in. You know, that I was involved in a medico-legal case where the biopsies were all negative, but there was a mass, and the patient was advised to have surgery, and it turned out to be benign disease. And on the consent form, they wrote, "You are having an operation for pancreatic cancer."
Right.
And he sued successfully because he said that consent form was incorrect. I never had a biopsy proven pancreatic cancer. I had a suspicion of it, and you should have consented me in a way that explained that there was a 5–10% chance that this was benign disease. And that's the sort of terrible situation that we're in, which is almost the polar opposite of what you have in Bangladesh. And I mean, I'm sure Zach will say, it got to the point where it is almost impossible to consent a patient, because our legal ruling now is you should tell people anything that a reasonable person would want to know. What does that mean? Who's a reasonable person?
It's also very challenging here in Bangladesh, because sometimes we see that when there is no son or daughter is available to counsel, sometimes his nephew, niece, whoever comes during the operation, and after the surgery, when there is a complication or something like that, they actually disappears. A new person comes in front of us to whom we have never seen him or said, so it becomes very much difficult during this period. So it's very challenging in others aspect that when there is a complication after the surgery, even after a simple wound infection, and when the targeted budget crosses the limit, then we face a huge problem. When to and where to treat this kind of patients, it's become a very challenging situation.
Yes.
I have a question to Dr. Robert, if you allow me.
Yeah.
Can I?
Yeah, absolutely.
Sir, we have encountered few difficult cases. One of the difficulties is that when a pancreatic borderline resectable cancer is bleeding or bleeding after the ERCP. So what should you do? We have done few of our cases. We are unable to dissect the supramesenteric area. So we have kept few amount of tumor tissue along the supramesenteric artery, considering patient's condition during the surgical procedures, because the patient may be, we have gone surgery with a hemoglobin of 6 or 7 with keeping a good amount of blood, because patient was having melena hematomesis. So what should we do in this kind of cases?
So yeah, so we've seen lots of people whose tumors are bleeding. We're fortunate enough to have extremely good interventional radiology and endoscopic facilities. So most of the endoscopic induced bleeds will be successfully controlled endoscopically as well. Most of the other bleeds we will treat with radiological embolization, and that might mean embolization of multiple vessels in series to see how successful each embolization episode is. The great thing about that area is it's quite unusual to cause infarction, because there's such a great anastomotic network of vessels around that area. But equally, that great anastomotic network stops embolization working that well. You know, we have certainly had, not many, but we've certainly had some cases where we have gone in and done an emergency Whipple for bleeding that we just can't control in any other way. And unfortunately, that may well be a palliative Whipple, because we never planned on doing the operation in the first place. But even a palliative Whipple will generally stop bleeding.
Can I share one of my experience with a case? A patient was having a periampullary carcinoma. He went undergone ERCP, and after that severe pancreatitis was faced, and it was difficult to do a Whipple's procedures as we are planning. There was every time there was peripancreatic edema and pancreas was swollen. So we were planning that we should be doing the surgery after control of the pancreatitis. But even after 6 weeks, actually I have waited for 8 weeks for the resolution of the pancreatitis, but it wasn't. So I thought I should go in and do something for this patient after the end of 2nd month. So I went in, but the fault I did that I immediately after the procedure, I didn't go for any CT scan. So in the during the surgery, I have encountered that there is necrosed tissue around the pancreas, not the pancreatic necrosis, peripancreatic necrosis. So I did the necrosectomy and did the biliary reconstruction, but didn't go for any diversion of the stomach. So I thought probably I'll be able to control it. I kept a drain in the lesser sac and also in the right Morrison's pouch. And after a patient was doing well, but it was very, the drain was dry in the lesser sac. That time, probably the 7th or 8th day, I have removed the drain in the lesser sac. So I thought that probably I'll go for resolution of the pancreatitis. I'll go for the neoadjuvant therapy followed by the surgery. But there was a pseudocyst. Patient developed a pseudocyst after that, and I did, with the help of my radiology colleague, Dr. Vishwajit Bhomik, I did the serially decompression of the pseudocyst, but I was not successful. But later began successful at the probably 3rd month. The pseudocyst disappeared, and finally I was able to go for the surgery. So what I want to know that whether my approach was right or I should be doing the surgery in the same setting.
Yeah, no, absolutely. You're right that the vast majority of people who get significant post-endoscopy pancreatitis, whether it be an EUS biopsy or an endoscopic stent, they represent a group who are a nightmare to operate on. And going in early is a disaster. You know, and I remember in my training, actually, I remember my boss telling me to do a Whipple post-pancreatitis. It took 13 hours to complete the operation. And we went to one of the IHPBA meetings not long after, and in the group he said, oh, I did this operation, it was post-pancreatitis, it took forever, but we did eventually get the tumor out. And then the patient had a torrid recovery and actually eventually died. And every single person in the room said, why on earth did you even try? and that was, you know, that was my lesson as a registrar. Don't go in and try and do Whipples in people who've got pancreatitis. It is not rewarding at all. The longer you can leave them, the better. Manage their pancreatitis. If their pancreatitis is not infective, you may even be able to tide them over with some cycles of chemotherapy, but the longer you wait, the more rewarding it is.
So, Rob, I think we wish we can continue much, but we need to finish up. So my last question, I had some few more, but due to the shortage of time, I'm not asking. We heard in the discussion, CT, MRI, PET, so many images. So for us, you know, what is the gold standard? I have everything which I should use, or other way around, in our country perspective, what will be the judicious use of imaging in pancreatic malignancy? Which imaging?
I think you are probably just as well off using CT imaging for a pancreatic cancer as you are MRI. And I think as CT imaging evolves and CT improves, it is very, very close to MRI. It may well be that MRI is the gold standard, but the unfortunate thing about MRI is you still need to get a CT of the chest because the MRI of the chest is not very good. So, so if I was going to argue a way of trying to make the pathway of a patient as quick as possible and as economically efficient as possible, I would say go for CT. You'll get very good information about the artery, whether that's involved or not. You'll be able to see if there's a mass or not. You'll have done your total body staging at the same sitting, and it's a one-stop.
Any addition by PET?
Now, we do PET scanning as well, and we do PET scanning on the basis of the PET-PANC study, and we do PET imaging on the basis that we have very easy access to PET imaging. If you don't, then I think it is not unreasonable to drop the PET part of the investigation.
So last question. Any comment?
Rafiq raised his hand.
Rafiq raised your hand. Rafiq, are you asking a question or you make it a question? Raise your hand. Rafiq Chapol. Rafiq. Okay. So somebody, I mean, Robert, I know that there are some situations when borderline resectability, SBRT is a very, hot cake to convert it in resectable to resectable, or neoadjuvant CTRT is done. So we are listening about chemotherapy neoadjuvant. Any very quick comments, doing radiation, then doing surgery, because very sensitive, we understand it's a very sensitive area, giving radiation, making it more risky than going for surgery.
Yeah, I think at the moment, the jury's out on whether you need to add radiotherapy to your neoadjuvant regime. There's a lot of evidence that FOLFIRINOX alone is a very good regime, and it does avoid those problems potentially of radiotherapy, although a lot of those problems are in the heads of surgeons rather than actual problems. And we found that out for rectal cancer. You know, we give people long course chemoradiotherapy. All of the surgeons went crazy and said, no, all of my joints are going to fall apart. Actually, it doesn't. But I think at the moment, radiotherapy is a very difficult subject to talk about with pancreatic cancer. And really, radiotherapy has become very difficult to talk about in pancreatic cancer ever since SPAC1.
Thank you, Rob.
SPAC1,
Yep.
you know.
Yes, please. Rob, I think you were trying to say something, please.
So me?
Yeah.
Oh, sorry. Yes. So I think I think radiotherapy. Yes, we do give it. We don't give it to everyone. We give it after discussion with the oncologist and based on either histology from a resected patient or what we're trying to achieve. But actually, I think at the moment, if you take radiotherapy out of the equation and you throw in FOLFIRINOX, I don't think you're going to disadvantage any patient.
Exactly. Totally agreed, Rob. So what we see that today, together we win. With the oncologist and you, the surgeon, we can do a great job because this is a paper published in Journal of American Surgeons in March 2021. They have done a retrospective review from 2010 to 2017, around 11,699 patients. And they have shown that adding chemotherapy with surgery is doubling the survival. They are not bringing radiotherapy in. So till now, I mean, in our next session, we will be talking about radiotherapy. Maybe we'll listen to that. Till now, we can keep chemotherapy and surgery together. And I think it is time to be busy with Copa America. This is solved, who is having the cup, but I think this is yet to be solved. I'm sure Rob and Jack both are quite excited and also a bit tense. So let's see who will smile. And until then, thank you all for joining with us. And our next session will be next Sunday, same time, non-surgical management of pancreatic and periampullary carcinoma, chemotherapy, radiotherapy, and palliative management. So with these few words, again, thanks to Rob, Dr. Zakir, and our today's presenter, Dr. Hasim Rabbi, and to all our participants for giving us time. We are sorry we have taken half an hour more time than the schedule because we covered two topics and we had some discussion and we have been sharing some thoughts. We wish we had some more time to discuss, but we need to finish because we need to give you time to get ready for the game, for the soccer. So now I think we can finish. Sir, are you there, sir? Hi, sir.
Yes, sir. Now we had a very nice time, very nice discussion. Thanks to Dr. Hasim Rabbi. He has presented the paper very nicely and very in details, elaborately. And also, many thanks to Dr. Robert. Has given us time and he has discussed the thing very nicely. He has discussed about the situations in his country and more countries. So, and also Dr. Zakir knows all the situation. So, I think we have lots of time. Thank you all very much and gratitude from Oncology Club. Hope to see you again next Sunday. Okay, bye everybody.
So thank you, sir. So thanks to our academic partner, Acuvida. And we hope that all of you will be supporting us in our continuous initiative. Rob, somebody may send you a mail, drop a line. Please try to respond if you are seeking your advice. Thanks to Zakir Bhai again. Keep on supporting us. Thanks to Hasim for the wonderful discussion presentation. And thanks to all our participants, inviting you all next week, same time, with no surgery, non-surgical management of pancreatic and periampullary carcinoma. But surgeons are also invited because you need to listen what we do. to handle this havoc. See you then. Stay safe. See you next week. Thank you. Goodbye.
Thank you very much. Thank you.